No more questions. I think I'll just introduce Dr. Vivek Gupta. He is from Ludhiana, Hero DMC. He has learned a lot of pioneer work in poisoning. Dr. Vivek Gupta, hand over to you for a cannulation in ECMO, VV, and VA. Thank you.
Thank you, sir. Thank you for the introduction. Good evening, everybody. So I'll be talking on the cannulation and ECMO, our strategies in the VV ECMO and V ECMO. I have nothing to disclose. So if we talk about the cannulation, it's actually achieving a vascular access. This is a prerequisite for initiating a ECMO. If your access or your cannulation is not appropriate, then you cannot achieve that. Initially, we used to think when we talk about the cardiac surgical patient, cardiopulmonary bypass, or ECMO in terms of cardiac surgery, that we used to think that the surgical approach used to be the gold standard. But now, over a period of time, we have learned that the percutaneous strategies are semi-surgical technique where we do combine both are also doing fine, and we are just incorporating this our day-to-day practice. What is important that when we talk about the cannulation, it is the flow which you need to establish to achieve adequate flow, whether it's a VECMO or VV-ECMO, you have to target the flow. And for that, it is important that depends upon the size of the patient. We select the right side, the size of the cannula, and the right length of the cannula. And nowadays, we use ultrasound to achieve to identify the vascular access while we are cannulating. The most important question comes where to cannulate these patients, whether in the emergency room or in the intensive care unit or in the operating room. Both have its advantage and disadvantage. If I talk about the ICU, the advantage is you don't need to mobilize these very sick patients. So there is no risk of transfer. It can be done very fast because it takes longer time to shift the patient and to reach to the OT, and you have to ensure that the OT availability is there. But issue is most of the time we don't have access to the fluoroscopy as we can do in the cath lab. And it's a less controlled environment because it's not so much of some contagious environment. So infection issues will be there. Our staff is not so well trained. And possibly a lot of machines at the small space in the bedside in the ICU. So it may be sometimes difficult to put a cannula this. However, if we talk about the operating room, it's a cleaner environment. Staff is very experienced for doing the surgical procedures. You can get the fluoroscopy. But again, the issue is unnecessary delay. And if the theater is not available, then you just keep waiting for it. And it is definitely resource intensive because once you take the patient to the theater, a lot of resource will be involved in that. So what is important for the cannula characteristic? What we need to achieve is the maximized blood flow with the minimal blood damage. All these cannula nowadays, what we are getting is the made up of polyurethane, which are basically a wire reinforced, and they are radio opaque, so you can locate their position. And since they are wire reinforced, so the chances of kinking or risk of kinking can be minimized. Now, what cannula we are getting, they have the surface coating either of heparin, bavloridine, or even some of the biocompatible material. Side holes are present. They can definitely improve the flow, but they can lead to a turbulent blood flow. Different shapes of cannula, it can be tapered, circular, and length of the cannula is always decided whether we are planning for the central cannulation or peripheral cannulation. Peripheral cannula is always a longer one. You will always get this kind of a chart in any standard textbook or in a study material that depending upon the age, which cannula we are selecting. So it is just a good guide depending upon the weight, but still you have to see the patient and what kind of a ECMO you want to achieve, whether VA ECMO or VV ECMO. Like in VV ECMO, you want a very high flow, nearly 80% of the actual cardiac output. So you need to put big cannula for the access cannula and a bigger size of the return cannula so you can achieve adequate flow with a minimal pressures. However, on the VA ECMO, you can select depending upon the age of the patient, size of the patient, and weight of the patient. What is important for us to remember that whenever blood passes through the cannula, there is a pressure drop when it enters and when it comes out. The difference should not exceed above 100 because it can lead to a hemolysis. So anything which decreases the length and increases the diameter will decrease the pressure drop, and that is favorable to us. But still, you have to make a balance between these, and you should choose a cannula of appropriate diameter as well as of the appropriate length. The cannula can have the different designs. It can have a central hole at the tip. Usually, we see this thing in the return cannula. Or there can be some central hole with some distal side holes around the tip itself. You can see this figure like this. So that is a lighthouse tip cannula, or you can have a multi-stage cannula. Actually, in the multi-stage cannula, you will see that this one, you can see a multiple holes, side holes at the different stages throughout the cannula, or interrupted multi-stage cannula, where you can see a multiple drainage pole along the cannula itself. The lumen can be 1 or 2 depending if we are putting a separate cannula for the access and return. It's a single lumen cannula. A dual lumen cannula, which was discussed in the previous talk as well about the Avalon cannula, or other cannulas are available which can place through single vein, and both access and return can be achieved with that. And depending upon whether they are connected, how we are going to connect with the tubing with the various size of connector, or we are going to connect it directly. It all depends depending upon the size of the cannula and what's the age of the patient. So this is how the cannula design is there. Different kind, access and return, but access cannula is always longer as compared to the return cannula. So how do we select the cannula? As I said, that these cannula should be as big as possible whenever we are getting an access, because this will we will have a liberty to increase the flow as much as we want, and moreover the resistance will be low, so the damage to the cells will be much lower. So drainage cannula is usually our access, our venous cannula, multi-stage. Usually for an adult patient, we put a 25 to 27 French, a longer one 60 centimeter, but it ranges from 31 to 30. We can select the size depending upon the size of the patient. The placement on the hepatic part of the inferior vena cava, we place and we always confirm with an ultrasound. The return cannula is an end hole cannula, usually 70 to 19 French. It's a 25 centimeter, but it can range from 15 to 23 French, which is placed on the right atrium or femoral artery, depending upon whether it's a VV ECMO or it's a VA. How do we measure the length? Average, usually for an adult patient, it is a 40 centimeter of the cannula from the Z-fistula. So you can always measure it with the wire, or you can confirm with using the ultrasound or echocardiogram. To ensure that there is no recirculation, means in cases of VV ECMO, if the access cannula and return cannula, means deoxygenated blood is being taken by the access cannula and oxygenated blood is being returned by the return cannula, if they come very close to each other, the oxygenated blood will go in the access cannula itself, and oxygenated blood may not be circulated adequately in the body. So that is very important that we keep a distance of at least around 10 centimeter, 8 centimeter, so that we can minimize the recirculation. And in cases of VA, usually we need a reperfusion cannula or distal perfusion cannula, which should be around 6 or 7 French. So we are taking one by one VA ECMO. VA ECMO can be done by the peripheral cannulation, or we can get it done by central cannulation. So peripheral cannulation, the most common configuration is the femoral vein and femoral artery. So usually we select these femoral vein and femoral artery, and we cannulate it, and we start the VA. Besides this, we can have the femoral vein and axillary artery combination. We can have the internal jugular vein and carotid artery combination, which is helpful in several ways, like we can mobilize the patient, and moreover, the upper body oxygenation of the coronary and cerebral circulation is also ensured, which is a difficult and may lead to Nassau syndrome in cases of femoral vein and femoral artery combination of VA. Or another combination is internal jugular vein or axillary artery. Central cannulation, which can achieve in cases of cardiac surgical patient, either directly in the ascending aorta in the right atrium, or in the ascending aorta and both the superior and inferior vena cava. So how do we do the peripheral cannulation? Peripheral cannulation can be achieved by using the Seldinger technique, means percutaneous technique, or modified Seldinger technique, which is semi-open, you open, expose the vessels, and then finally you cannulate we do for the Seldiger's technique under vision. And the third one is the open or surgical cut down, when you totally expose the patient, make a cut down in the vessel, and you place the canal. So we'll be talking one by one for the each technique. Percutaneous technique, it is accessing the peripheral artery and vein with the minimally invasive Seldiger's technique. You can see in this diagram, it has been placed percutaneously. So it does not require any surgical access. You can achieve it very, very quickly. And skin itself, you can see, appreciate that skin has made a tight seal so that there is a minimal bleeding, because it's a uh, there is no leak from the vessel, and minimal blood loss is there. And distal perfusion, you can see we have achieved a distal perfusion also percutaneously to ensure that there is no distal limb ischemia. So this is a very fast technique, easy, but remember, insertion is a very easy and a lot of benefits. But when we remove it, it has to be done surgically. You can't do it directly like we do for the any removal of the any vein, that we put the pressure and we take it out. It has to be done surgically, and surgically the vein and the artery and vein has to be repaired. So how would you do the Seldiger's technique? We all are well aware. We ensure that our needle tip is in the vein. We place a guide wire over it, and while placing, this is very, very important step. You should always remember that while placing the guide wire, you should not have any resistance. Once you have placed the adequate guide wire without resistance, you use the serial dilator to dilate the vessel. And again, this is important here to remember that you should not apply any force while using the dilator. Otherwise, there is more risk of vascular injury. And when you have achieved adequate dilatation, you can always place the cannula and confirm the position. To do percutaneous cannulation, you can see this. This is the arterial cannula, and these are the venous cannula, longer one, blue colored. Along with that, other equipment required like guide wire, puncture needle, and the different size of the dilators you can see. This is one of the studies that was published in 2012, that they did 15 cases of VA ECMO percutaneously in 2 years, and what they could see that there was 40%, 47% of the complications, out of which almost 40%, 38% were the vascular complication in the form of ischemia, retroperitoneal hemorrhage, distal limb ischemia, thrombosis, or dissection of the vessel. So you can understand there's it is associated with a lot of complication. So it should be restricted only for the emergent situation when you do not have a vascular surgeon, or you can't do it because patient is having cardiac arrest, or you are doing an ECPR. This is another paper which has shown that the incidence of vascular complication was very high in the VA ECMO in comparison to the VV ECMO. So use of ultrasound has definitely reduced these risks, because when you do it ultrasound guided, you are aware about the vessel size as well as the placement of your needle and confirmation of your guide wire. And both cannula as well as distal perfusion cannula, both can be inserted with the use of ultrasound guidance. You can see here, this is how the cannula in the VA ECMO arterial cannula goes. You can see the femoral artery, and it is passing through and reaching beyond the bifurcation. And this, you can appreciate that this is the distal perfusion cannula, which is connected through the vessel, through the the cannula, the arterial cannula, and it is perfusing the distal part of the limb to prevent any limb ischemia. The second technique, what we do, is a modified Seldiger's technique. What we do here, we surgically open the vessel, and in this manner, in the paucity of time, I will not show you this video. So we open it surgically, the vessels are exposed, and under vision, we put the needle followed by guide wire, so that in the manner we do for the Seldiger's technique, so that the vessels itself make a tight seal around the cannula, so that there is a minimal chance of bleeding. And even surgeon now are placing the first string suture before placing the cannula, so that in cases of vasodilatation was the V ECMO is continued, in those conditions, they can tighten the first ring suture and they can prevent the bleeding from the surgical site. This is open technique. Here you can see, appreciate that the wound is, there is a surgically open scar and the under vision that there is a hole in the artery and the cannula has been placed and it is taken out through the skin. Even we can place a side arm graft so that in cases where we are worried about the distal perfusion, we can always put a side hole graft and we can connect the cannula through this so that there is no occlusion of the femoral artery per se. You can see this, you can appreciate it is connected like this. Similar the kinds of cannulation can be done in cases of axillary artery, where you can see the axillary artery is connected with the graft and internal jugular cannulation is being used as an access canal. The pediatric cannulation, less than 2 years of age, we do a carotid artery cannulation and internal jugular vein cannulation because the femoral artery has not so developed. In the bigger child, we can use the femoral access for a cannulation purpose. You can see this is the femoral artery and this is the distal perfusion cannula, and you can see that the 15 French venous cannula has been placed in the left femoral vein. So for pediatric cannulation, if the age is less than 2 years, carotid ligation and we can do the carotid cannulation and internal jugular cannulation. If the age is above 2 years, we can try for femoral cannulation, but a femoral artery cannulation, but you should be very careful about the limb ischemia. If there's a limb ischemia, then we can see if the patient is ready for weaning. If not, still ischemia is persisting, we try for the distal perfusion. But if there is no limb ischemia, we can continue the monitoring and we can continue with the ECMO itself. The other component is the central cannulation. This is basically when we are performing a cardiac surgical procedure in post cardiotomy and patient is not coming off bypass. We continue with the same cannula. We take out these tubings and we place this patient on ECMO. Definitely, it is superior because we can achieve the higher flow. The drainage is better, and we are not worried about the upper body hypoxemia. Coronary and cerebral circulation is being taken care of because oxygenated blood is being perfused in the ascending aorta as well. It is useful in cases of peripheral vascular disease as well because in those conditions you are not worried about the limb ischemia. But bleeding is a big risk, infection is a big risk. So many things are associated with the central cannulation. So one should be very, very careful for doing because you are going to do the sternotomy when you are going to place cannula at the central position. So usually it is restricted to the post-cardiac surgical period. This is what you can see the central cannulation. You can the cannula is placed in the ascending aorta itself, so that all perfusion are taken care of by these cannula placed in the aortic ascending aorta. Besides this, when we are using the open technique, we can directly place the LV vent, which you can see here. It has been placed on the apex of the left ventricle so that we can do a good decompression of LV. Otherwise, we can do a percutaneous atrial septostomy in cases of peripheral cannulation that is done in the cath lab under the fluoroscopic guidance. Coming on the veno-venous cannula, veno-venous cannulation for VV ECMO. Here, we can do a femoro-femoral cannulation, or we can do the internal jugular and femoral cannulation, and we can do an internal jugular cannulation using a double lumen catheter. So the most common combination what we use is the access, femoral venous access and internal jugular return. That's the most common one. We can use the femoro-femoral, which we have commonly used in cases of COVID patients, and the dual lumen catheter, which is not easily available in India. So you can use only internal jugular vein as a single access, which will be useful for access as well as for the return of the oxygenated blood. So this is a femoro-jugular combination. You can see we are using the left femoral vein for access and oxygenated blood is being returned to the patient in the right internal jugular vein. So this is one of the most common combination because there is a minimal risk of recirculation. So this is how it goes. This is the access. You can see this, the oxygenated blood is coming to the pump, reaching to the oxygenator, getting oxygenated, and now it is being pushed back to the vein, right internal jugular vein, and oxygenated blood is now reaching to the right atrium and finally reaching to the oxygenated blood to reaching to the lung and being circulated in the systemic circulation. So this is how the cannula on X-ray looks like. You can see this is the jugular cannula, and this is, you can appreciate the femoral cannula, and there's a good distance between these two cannula, so you can minimize the risk of recirculation. So the dual site VV cannulation, you can have the different combination. You can have this, you can see this. This is the drainage cannula, which is placed in the hepatic part of the inferior vena cava, and it is being draining. And now, after returning, it is reaching to the right atrium. This cannula is placed in the right atrium. So this oxygenated blood is coming and now passing through the lung, and it is reaching to the going to the systemic circulation. The other femoral, you can see this access cannula. The return cannula is the bigger one, which is placed on the right side, and access cannula, which is placed on the left side, drainage cannula. You can see this, and now it is getting oxygenated and going back to the patient. You can appreciate the position. The access cannula is kept lower down to minimize the risk of recirculation. So oxygenated blood, which is being returned through the return cannula, is kept on the higher position in the vessel, so that we can minimize the risk of recirculation. Now, this is another combination. This is the you can use the drainage cannula. You can return this oxygenated blood to the pulmonary artery itself. So what you can see here, this is directly going to the pulmonary artery, PAVV ECMO, so that there is no chance of recirculation and oxygenated blood going to the pulmonary artery, and finally from the lung it is reaching to the left side of the heart. So you can minimize the risk of recirculation. Coming on the double lumen cannula, here the single vein is used, that a right internal jugular vein, which function as an access and return function both. You can see this is the access cannula and this is the return cannula. So basically there is a bicaval drainage and the return to the right atrium. But what is important, the cannula position is very critical, because your access cannula should, the port should be in the IVC, and SVC drainage should be appropriate, and your return cannula should be positioned in a manner that it is directed towards the tricuspid valve. So you have to confirm the position by using sometimes the transesophageal echocardiography. So placement is a bit difficult. There is a risk of displacement, and sometimes while placing you can do a perforation. The flow is limited and definitely it is costly. Now you can appreciate. See, it has this is the IVC port, this is the SVC port, and you can see this is directed towards the tricuspid valve. So oxygenated blood, these two are the drainage one, and this one is the return one. So you can see, but the advantage is patient can sit comfortably, patient can be mobilized, and you are using just one access, so the risk of infection and other complication can be minimized. You can see here the oxygenated blood is being taken, and after oxygenation it is being returned back to the patient to the same cannula with a different port, and it is directed towards the tricuspid valve. So different manufacturers are there: Avalon, Novaport, and Origin, of the different sizes. The length is usually from 20 to 30 centimeter, and they have the different pressure gradient. However, all have the almost similar feature, that kink-resistant material. They are radio opaque, and they are reinforced with the wire. So there is no kinking or compression of the cannula. What is important, that if we are not able to cannulate, it means we cannot initiate the ECMO. So this is very important, that while cannulating, you should be very, very careful. You should always have a backup help so that you achieve an appropriate cannulation. And if cannulation is failed, there is a risk that patient may die immediately, because you are putting a ECMO either for VA or VV support, which cannot be achieved. The common reason why we get cannulation failure is sometimes the patient is very obese and we are not able to get an access. Or when we are doing CPR, and during CPR, because of a lot of movement is in progress, so you may not achieve the access. Our patient is having some vascular calcifications or peripheral vascular diseases or scarring over the body, so that it is difficult for you to achieve the cannulation. While doing a cannulation, there is a risk of bleeding, especially for VA ECMO. There is a risk of hematoma when you puncture the vessel through and through, or there is a risk of retroperitoneal hematoma, or you can perforate the vessel. So all these the complications are very common, And how to avoid this complication? This is very important that whenever we are using a Seldinger technique, placing needle, achieving a good flow, and passing a guide wire without resistance, and using the dilator without the force, and while placing the cannula, you rotate the cannula rather than pushing it in. And if you feel any resistance, ensure that your cannula position is correct. Sometimes there is a risk of decannulation, accidental decannulation, when you have an inadequate fixation. So you should make sure that you are fixing it appropriately and do not place multiple catheter, as you can see here, has been placed through the cannula itself. So there is always some pulling can lead to a risk of decannulation. You can see, appreciate here that there is a perforation of the vessel. It has gone uh, outside the vessel area. Other complication, we can have the limb ischemia in cases of VE ECMO when distal perfusion is not achieved, or even after the distal perfusion itself, there is a risk. Sometimes there is a difficult puncture, so there is a risk of bleeding, vessel perforation, or vessel dissection or injury during cannula placement. There can be upper body hypoxia in cases of VE ECMO. So we need to add another cannula in the jugular. So we convert, as Dr. Pranay Oja was talking about, VAV ECMO. So we have to switch over to the hybrid ECMO. There can be risk of vascular complications. Can be significant bleeding when we remove the cannula, or sometimes the cannula is dislodged or dislocated, and there is always a risk of wound infection. So to conclude, what is important for us to remember that when we want to put a patient on ECMO, the cannulation is the most important thing, and uncomplicated cannula placement is key to success for initiating a ECMO. Technical improvement, especially with cannula design, king-free cannula, Seldinger's technique has improved the success rate or successful placement of these cannula. Still, remember that complications do happen. Always ready for the to handle the complication. How we do it? We must ensure that there's a multidisciplinary team which are helping us, and there is always a backup vascular surgeon. Ultrasound guidance is definite for placing the percutaneous placement of the cannula and should always be used. Appropriate preparation, always keep a few units of blood arranged while inserting. Follow the right technique, and you must be trained adequately. Always keep a surveillance over the while placing the cannula and while fixing the cannula and while maintenance of ECMO. What is important? Never panic, never force. If you force, there is a more risk of vascular injury. So remember, when you need some force for the placing the cannula, it means there is some issues, and reconfirm it before you insert these cannula. Thank you very much. If you have any question, I'll be happy to answer.
Thank you, Dr. Vivek. We go to the next speaker, and just a message that we'll keep a 15 minutes break for dinner at 9:30 p.m. Because there was inquiries about dinner time. So the next speaker is now Dr. Nand Kishore, who will speak on initiation and monitoring of ECMO.
Good evening, everyone. I'm Dr. Nanda Kishore. I'm a pediatric intensivist at KIMS Hospital, Hyderabad. This evening, I'm going to talk about initiation and monitoring. I have nothing to disclose. Let's start with initiation. So initiation process starts right from you get the call for ECMO. So a lot of success of ECMO depends on choosing the right patient for the right indication and initiating it at the right time. And look at what are available resources and expertise. Do you have all the people or do you need any other help? And where are you going to initiate? Are you going to initiate ECMO in ICU, emergency room, in theater, or cath lab? A lot of it depends on how sick is the patient and what other co-interventions patient would need. And decide what mode of ECMO you're going to go on. Is it going to be respiratory support or is it going to be cardiorespiratory support? In that case, veno arterial mode of ECMO. Or is it going to be one of those hybrid modes? Once you decide on that, before you even touch the patient, take the consent from the family and prepare the part. What I mean to say is, especially if you're going on a venous ECMO and we're going to cannulate the femoral vessel, expose the pelvic area and shave the pubic hair so that it'll be easy when you go on ECMO. And many times we actually realize this after scrubbing is not being prepared and we have to wait for some time for it to be prepared. So you can avoid those time delays. And to arrange for the right size of cannulas and dilators. So when you choose the cannulas of at least one or two sizes different. And usually we do it by ultrasound guidance for cannulation, especially if you're doing the percutaneous cannulation. Other mode is to do an open surgical technique where you look at the vessel size and decide the cannula. But ultrasound helps a lot in that situations. We'll come to that, how the ultrasound helps in the next slide. And once you arrange for the cannulas and dilators and open the circuit, usually what we do is the saline priming. So you run the saline through the circuit before connecting it to the patient. But sometimes you do blood priming, especially if the patient is anemic, already pre-existing anemia is there. Or in case of children, where their priming volume itself is equivalent to child's blood volume, where risk of dilution anemia is there. So we do blood priming in those situations. And then think about what is your anticoagulation strategy. Generally, when the patient goes on ECMO, then we give 100 units per kilo of heparin bolus, 100 units per kilo of heparin bolus. When the patient is already coagulopathic and bleeding, and then we give slightly less doses. Sometimes there's the instances where we went on the patient heparin-free also. But that kind of rare situations. And then determine the cannula insertion length, how far the cannula insertion are you going to put in. Generally, what we tend to do is I tend to measure from xiphisternum to inguinal ligament for a venous mode ECMO, where you're going to use femoral vessel and jugular vein. For jugular vein, I usually measure from the sternal angle to the middle of the neck. And then once you put the cannulas, connect those cannulas to the circuit without air entering into it. And then one need to have a real hands-on experience for that, how to do it, which you're going to learn in hands-on sessions over the weekend. Sorry. Once the patient is connected to the ECMO circuit, all this circuit is clamped so that you will not expect any flow, or there won't be any blood flow from patient into the circuit, a reverse flow. So what we tend to, once you connected everything, then you increase the revolutions per minute to 1000 RPM and then unclamp the circuit. And you usually unclamp on the venous side and then unclamp on the arterial side. Then slowly increase the flow to the required support. If it's a venous mode ECMO, one would need anywhere between 80 ml to 120 ml per kilo per minute. Usually, the neonate or small children, higher the flow. So usually with neonates, we go to 120 ml per kilo per minute. In adults, we go to 80 ml per kilo per minute. That is to begin with. And then depending on the requirement, and then you adjust the flows. Similarly, for veno-arterial mode of ECMO, we go for 3 liters per meter square per minute of cardiac output. So which would roughly translate into 100 ml per kilo per minute in neonates and infants, and 60 to 80 ml per kilo in children and adults. Then as you increase the flows, you increase the sweep gas to match it. Usually what we do is 1:1. So what it means is if you increase the flows to 1 liter, then you increase sweep gas to 1 liter. If you increase the flows to 2 liters, increase the sweep gas to 2 liters to match it to that. And then once the patient is stabilized, you do blood gas, and then you adjust the sweep gas according to that. So when the patient goes on ECMO and stabilizes, he would not need a high pressure ventilation. So you usually back up from the ventilator to the minimal settings Aim is to keep the lungs open at the same time. You're not causing much injury to the lungs. Similarly, we need to come down on inotropes as well, as per the requirement, go by the hemodynamics. If it's a vena-venous mode of ECMO, generally we should be able to come off all the inotropes, because usually that inotrope requirement, because of hypoxemia, and then once you correct hypoxemia, inotrope requirement should go down. In a veno-arterial mode of ECMO, where you've initiated ECMO for the weak heart, poor heart function, then you might need some amount of inotropy for the heart to function. But we probably may need to come off vasopressors, but leave some amount of inotropy in the background. So once you got the adequate flows and patient stabilizes, you confirm the cannula position. Usually what we tend to do is at the bedside echo, by transthoracic echo, looking at the cannula position and secure the cannulas. And then later on we get X-rays to confirm the cannula position. So this is what I meant by ultrasound guidance for the cannulation. What we tend to do is we measure the vessel size on the ultrasound. Then that gives a rough diameter of the vessel. That'll give us some idea what kind of cannula I can choose. Usually cannulas, everyone need mention what is the outer diameter of the cannula on the mark. It usually says what is the diameter of the cannula as well. So that kind of helps us to choose the right size of the cannula. So this is a guide wire which we use, usually 150 to 200 centimeters. Stiff guide wire, we use it with J-tip. And then you get two kind of cannulas. Return cannulas is a smaller one with a single opening at the end. And the drainage cannulas, which are longer and with multiple holes. Generally in a typical adult, say example of 70 kilo patient who is going on ECMO for ARDS, we typically go off a drainage cannula of 25 to 27 French drainage cannula, with the return being anywhere between 22 to 21 return cannulas. So usually return cannulas are slightly smaller than the drainage cannula in terms of length and in terms of diameter. Now coming into dilators, if you get a dilators along with the cannulas, that's a good. You can use those ones, but many times it's not possible and they're quite costly as well. So this is the kind of, we found it a good alternative which is less expensive. So these are the urethral dilators. So we take a sterile urethral dilators and use it. It comes in a different sizes and quite useful to dilate the vessels and at the same time cost effective as well. So this is a pediatric patient went on veno-arterial mode of ECMO for viral myocarditis. So yeah, this is a drainage cannula which is put into the percutaneous method, and this is a return cannula which done by open cut down, by surgical cut down. So we put a cannulated the femoral artery. Because we cannulated the femoral artery, so we worried about the distal perfusion of that leg. So to prevent the distal perfusion problems, we put another cannula to maintain the distal perfusion. So this distal perfusion catheter again connected to the main cannula through a Y junction, which is not shown here. And this is a veno-venous ECMO where the drainage line is in the femoral vessel, and then this cannula is fixed along the long axis of the thigh, and then we took a loop and fixed again to the thigh. And similarly, the neck cannula, we fixed along the neck and they took a loop and fixed onto the chest. So this kind of helps us to minimize the cannula movement, and whenever the patient moves, cannula also moves along with the patient. So there are some problems one need to be aware of while initiating. So because we're going to cannulate the big vessels and put a guide wire, so there's a risk of these big vessel injuries there. And if you're not careful enough, then always chance of wrong track formation is there, especially if an obese patient, if you're not able to navigate your dilator through underneath the inguinal ligament, there's a high risk of wrong track formation is there. If that is the case, then if you anticipate that, maybe better to go for a open surgical cut down and cannulating the vessel. And many times we put these guide wires and cannulas into the heart. There's a risk of heart perforation, especially right atrium. And there are instances it actually right heart was perforated and we had to cut open the chest to rescue the situation. At least for this reason, one need to surgical backup whenever you Even when the surgery is not done, we need to have a surgical backup to bail out those kind of situations. Once the patient goes on ECMO, the risk of systemic inflammatory response because of non-endothelial surface of the ECMO circuit. And then one can get into capillary leak, and you would need a lot of fluids to fill that capillary leak. If the patient is already septic and capillary leak situation, and going on ECMO may make things more worse, and you would need a lot of fluids to compensate that. If the patient is hypovolemic or intravascular hypovolemia is there can be chattering of the tube, which we'll show in the next video. So if the tube is a certain jerky movement of the tube is there, circuit is there, that means there's not enough volume in the patient. So we need to give more volume. We also need to be aware of certain metabolic abnormalities which can arise while going on ECMO, especially if you use the blood prime. So what we tend to do is we always do a blood gas when you're doing blood prime. So that kind of tells us what is the potassium level immediately. And usually we tend to use as fresh blood as possible. And similarly, the patient is risk of hypocalcemia because the citrate anticoagulation in the prime blood can chelate the calcium, and patient is at risk of developing hypocalcemia. So we need to be aware of that. And if you veno-venous ECMO, when the cannulas are too close to together, the risk of recirculation is there. This is a video showing a charting of the tube. So if you can appreciate the sudden jerky movement of the tube, that means the hypovolemia is there, chattering is there, and at the same time flows are also coming down. No, that's a jerky. That's what I was talking about, not the pendulum movement. That's a jerky movement which is seen, that is chattering, and the same you can see the flows have come down even with revolutions of 3,400. And if everything going well, we should see the good color difference between the venous limb and the return limb. So deoxygenated looks dark red and oxygenated limb looks bright red. So if there's a good color difference, that means it's doing well. If the both limbs are bright red, that means a lot of recirculation is happening. If the both limbs are dark red, that means there's not enough oxygen getting into the oxygenator. This is X-ray showing the two cannulas are too close to each other, then the risk of recirculation is there. And if recirculation is there, it is two limbs to be bright red. And then you need to adjust the cannula position to see a good color difference between the return and drainage limb. Then coming to monitoring, for discussion sake, we can categorize into circuit-related monitoring and patient-related monitoring. So one needs to be familiarized with the equipment to troubleshoot. It is very essential. And one of the main aim of this workshop is so that everyone is familiar with what they're dealing with. And then when the patient goes on ECMO, what we're aiming at is adequate flow. So what we're targeting is the flows. But to get to the flows, what we change is the revolutions per minute, that is RPM. So typically what we say, if we need to increase the flows, we go up on the RPM. So that's what normally happens. But be aware that that equation is not the same always. The reason is most of these ECMO circuits are centrifugal pumps. So what it means is they're preload and afterload dependent, like a normal heart. So what it means is if the patient is hypovolemic, even for the same RPM, you may not get good flows, or you might need a higher RPM to get the flows. And sometimes you can see there can be chattering of the tube. So in those situations, you give volume and then the flows goes up with the same RPM. Similarly, if there's a obstruction or a kink in the return limb, for the same RPM flows would come down. So then we need to look for, is there any obstruction there, or is the cannula hitting against any vessel wall? And then we need to address those issues rather than just going up on the RPM. And then you measure the pre-pump pressures. So that tells us how much negative pressure we need to suck the blood from the patient into the circuit. So usually we measure it, and if anything more than -30, that means too much negative pressure. If it is more than that, you can see chattering of the tube. So what it means, if the more negative pressure is there, and then you would need volume to maintain an optimal zone. Similarly, we also need to measure the pre and post oxygenator pressures. And what we're interested is in the difference between the pre and post oxygenator pressure difference. There's no set number for this. Again, depends on what kind of oxygenator you use it. So different oxygenator have slightly different numbers, but again, there's no specific number for any oxygenator. What we're interested is when a patient goes on ECMO, document what is the difference between pre and post oxygenator pressure difference. That is delta pressure. So that tells us what is the pressure drop in the oxygenator, and you document that and see what happens to that over a period of time in the next few days or weeks, depending how long the patient is. And the pressure difference is increasing. That means there's a increased resistance oxygenator, which most likely because of some clot formation in the oxygenated tubes. So if the pressure difference is too significant, that means there's a risk of oxygenator failing. So we need to identify that even before it happens. So we need to monitor that. In that way, it's pre and post oxygenator pressure, we need to measure it constantly. And then we need to check the anticoagulation status. And ACT, activated clotting time, is one of the most widely used tests at the bedside. And it gives the result instantly. And what we're aiming for is anywhere between 180 to 220. So again, depending on the patient anticoagulation status. If the patient is bleeding, then you're trying to maintain slightly lesser ACTs. Or there's a clot formation, pre-existing clots are there, or some clot formation happening over a period of time, then you tend to maintain slightly higher ACTs. But bear in mind that ACT is very good test and quite useful at bedside, but not always sensitive. So what we tend to do is we usually back it up by APTT. So we do a ACT when the patient goes on every couple of hours and the patient stabilizes, and then we do it every 6 to 8 hourly. And then we back it up by at least once or twice a day APTT. And when you do APTT, what we're aiming for is 1.5 times to twice the normal. And somebody has the facilities to do a thromboelastogram, then you can do it. And then what we find useful is the patient is bleeding, and then if you do not able to pinpoint what is the reason for bleeding, or if you want to give any blood products, then TEG is quite useful in that way. But commonly used is the ACT and the APTT. And then we do a blood gas from the oxygenator once a day. So that kind of tells us the efficacy of the oxygenator. So usually when the patient goes on ECMO, then we would expect oxygen PaO2 anywhere between more than 300. And generally it usually is in around 400 zone. If it is anything less than 200, it's a bit of worry. So which was when a patient goes on ECMO, the PaO2, which was 300 to 400, is come down to 160 now, and say at the same time pre and post oxygenated delta pressure difference also increasing. That means that oxygenator is going to fail. So we need to act quickly. So rather than wait for it to fail completely, you preemptively anticipate that and change that oxygenator. And also look for the cannula position every shift. So once the patient goes on ECMO, document how far the cannula went into the patient body and document that. And have a transparent dressing when you put in patient, and check that cannula position every shift and document it. So that kind of tells us whether the cannula is moving or not and how far it's moved. And also similar serial X-rays also helps us to check the cannula position. And every shift we do a circuit check starting from one end to other end. Starting from either you come from the venous end or the arterial end, but one end going through all the way through the circuit to other end, mainly looking for any clot formation, to check all the connectors are tight, there's no leakage, there's no air into the circuit. And one good piece of instrument required at the bedside is a torchlight. So this should be at the bedside always. And whenever you do a circuit check on another end, we put a torch and walk it through all the way through one end to other end. Coming to patient-related monitoring, it's like any sick patient in ICU, they would need a serial monitoring of the vitals, and they would need more frequent investigation in terms of hematology, metabolic, and blood gases, because they're quite sick patients, and they would need neuro observations. And many of these patients are heavily sedated and paralyzed, and they're anticoagulated, and there's a high risk of any neurological event. So we need to monitor these neuro observations along with the vitals. So we document those things along with the vitals. And if it's a veno-arterial mode of ECMO, we need to monitor the cardiac function serially, because in veno-arterial mode of ECMO, there's a significant afterload increase to the heart, which is already compromised. So the risk of left atrial hypertension and heart dilatation might be happening. So we need to monitor that and take measures. So usually what we do is we start some kind of inotropy to increase heart contractility. And even that failing, then you need to do a left heart decompression. So that itself is some other topic. We'll deal with it. But one need to monitor for the cardiac function. And what we're looking at is whether the heart is able to decompress or not. Similarly, when you cannulate the artery, what we're looking at is the distal limb perfusion. So even though you put a cannula into the distal limb, so you want to make sure that that perfusion is enough to that leg. So, and then because this is a constant flow, not a pulsatile flow, we won't be able to feel the pulse, or neither we won't be able to get pulse oximetry on the limb. The one way to know it is clinical examination, looking at the color of the limb, capillary refill time, and temperature. And other way is to do a ultrasound to see what is the flow. So we need to monitor that, make sure that flow is adequate. And if you have a facility, sometimes we also, if a changeable flow probe is there, we put a flow probe onto the distal limb to see how much is flowing going to that leg. Then many of these patients in heparin, so the risk of bleeding is there. So one need to monitor for these bleeding risk. If anything superficial, we can control it, but anything deep inside, we won't be able to know. So we need to monitor for those very closely. If it's infants, we do a serial head ultrasound where the anterior fontanelle is open. And there need to be a lot of analgesia and sedation, so we need to monitor specific monitoring for that. And we need to document all these things to see what's happening serial trends. So this is the patient, pediatric patients we put on ECMO during COVID times. He's around 1.5-year-old, went on ECMO because of COVID ARDS. So here we cannulated the carotid results. So we cannulated the carotid artery and vein. Because we cannulated the carotid artery, so we wanted to make sure that that half of the brain is perfused from the circular villus from the other side. So we put a NIRS monitoring to look for the cerebral saturations, and you can see the similar saturation both right and left. So that kind of reassures for us to say that even other cannulated side of the cerebrum also being perfused well. So to conclude, for successful initiation and monitoring, a lot of it goes down to how much you prepared and anticipated the problem so that you can mitigate these problems even before they arise. And going in sequence always helps, and having a checklist so that even one step is not missed out is quite useful. And team training is quite an essential part of that, because the many people are involved in the ECMO initiation, not just a doctor. They're going to be doctors, nurses, perfusionists, respiratory therapists. So we need to have a coordinated team work for that. And we need to document these trends, what's happening with the patient, as well as the ECMO circuit and the patient, what's happening with these things, and how they're correlating with each other. And, ECMO is a quite invasive mode of treatment and a lot of complications associated with it. And when it arises, sometimes we will not have time to act upon it. So we need to have some kind of a backup plan. What if something goes wrong? Whom are we going to call? How are we going to deal with it? Especially in the middle of the night, not many people are around. And one important thing is the communication with the family. Many of these patients, when you go on ECMO, we need to prime the family that they're not going to get better in 2-3 days' time. At least they may get better in a week or two. Sometimes if it's a COVID or something real bad ARDS, it may take weeks. So we need to make the family prepared for that. Otherwise, it's going to be big trouble to deal with them later on. So, and the communication goes a long way for successful ECMO as well. So with that, I'll conclude. Thank you very much. I'm ready to take any questions if there is anyone. Thank you.
Hello. Yeah, with this we'll go to the next talk.
and that is on management by Dr. Rakesh. We have two talks of Dr. Rakesh. One is management and then sedation and analgesia. So we'll have one by one talk after that.